Good afternoon, everyone, and welcome to the Hartford Institute for Geriatric Nursing's webinar series addressing current trends and issues impacting the health and well-being of older Americans. We have these webinars around every 6 weeks to 8 weeks, and we always try to address issues that are very important to our policy agenda, as well as for healthcare professionals in these days and in this environment. I'm Dr. Tara Cortes, the Executive Director of the Hartford Institute for Geriatric Nursing and a professor at New York University Myers College of Nursing. This featured webinar is part of our 25th anniversary celebration, and I'm particularly pleased to see that we have more than 250 people registered to learn more about this important issue. Our program today, Changing the Landscape of Health and Healthcare Equity, will address some of the inequities in this country that contribute to health and well-being. And of course, these inequities impact people throughout their lifespan and have a cumulative effect on people as they age. We have placed in the chat box an interesting publication that came out just yesterday from the Commonwealth Fund addressing inequities across all the states in this country. I encourage you to read it. It's a very interesting and enlightening read. Now to introduce our panelist. Dr. Jasmine Travers is an assistant professor of nursing at New York University Rory Myers College of Nursing. Her career is dedicated to designing and conducting research to improve health outcomes and reduce health disparities in vulnerable older adult groups using both quantitative and qualitative approaches. Her current work focuses on mitigating disparities in appropriate access and use of in-home and facility-based long-term care for older adults. As a health services researcher, she has leveraged many data sets to investigate these issues. Dr. Travers has published widely on the topics of aging, long-term care, health disparities, workforce diversity, infections, and vaccinations. She's presented her work at regional and national health services research, gerontological, nursing, and public health conferences. Our second panelist will be Jennie Hanson. Jennie Hanson is the immediate past CEO of the American Geriatric Society, the largest membership organization of gero clinicians committed to the care of older adults living with care complexity. Prior to this position, she completed her role as president of the 38 million member AARP during the negotiations and development of the Affordable Care Act. Her primary career includes 25 years in San Francisco, providing integrated, globally financed, and comprehensive medical and community-based services for nursing home eligible older persons. Its groundbreaking, fully capitated, integrated, and coordinated service delivery system became the prototype for the 1997 federal law that incorporated the Program of All-Inclusive Care for the Elderly, PACE, into the Medicare and Medicaid programs. PACE now operates extensively in California, as well as in 30 other states. She has served as a federal commissioner on Medicare and currently serves on several boards related to healthcare and philanthropy. In January of 2021, she completed her formal role as one of the stakeholders who crafted the first ever California Master Plan for Aging. She currently serves in advisory roles with startup companies and on health system and related boards. For nearly 4 years, she's been a consultant to establish geriatric emergency departments in San Francisco. Recent awards include the American Society on Aging's ASA Hall of Fame Award and being named one of the national 50 influencers in aging by PBS's Next Avenue. 2 years ago, she was awarded an Audacious Alumni Award by the University of California, San Francisco. And in July 2021, she was recorded as one of ASA's Legacy 12 interviewees. In addition to being a fellow in the American Academy of Nursing, she's received several alumni awards from the University of California, San Francisco, and Boston College, including an honorary doctorate at Boston College. Susan Carney Lynch is a senior counsel for elder justice at the Department of Justice, where she has been civilly prosecuting healthcare fraud cases for over 20 years. Dr. Lynch is the department expert on failure of care nursing home cases and is the national lead for the department's 10 elder justice task forces across the nation. Dr. Lynch is also a national lead on the department's new elder justice coordinator training. And she's resolved some of the department's most complicated nursing home cases, obtaining the department's largest civil settlements in these matters. Dr. Lynch also works extensively on the department's elder justice policy as part of the department's Elder Justice Initiative and has her doctorate of public health in health policy from the Johns Hopkins Bloomberg School of Public Health with the focus on gerontology. Dr. Lynch also teaches as an adjunct professor of law at the George Washington University Law School. We're delighted to have such a prestigious panel with us this afternoon. We look forward to hearing them, and we also look forward to your participation through the questions and answers. If you have a question, please put your question into the Q&A rather than in the chat. Use the chat just to chat with each other, but put your questions in the Q&A. And we'll have the presentations followed by a discussion amongst the panelists, and then we will open it up to questions. Dr. Travers, would you begin, please?
Sure, thank you. Let me just share my slides. There we go. So just thank you, Dr. Cortes, for that warm introduction. And I am so excited to be speaking on this esteemed panel today. So thank you for the invitation as well. So I get to set the stage for health equities or inequities. And the title of my presentation is Dismantling Structural Inequities Behind COVID-19 Aging-Related Disparities. So I want us to imagine this. You're an 86-year-old older adult who walks with a cane, lives at home by themselves, has no children, no internet, no smartphone. You've been forced to stay in your home for 8 months in the midst of the COVID-19 pandemic because you are considered high risk with a history of diabetes. You've had limited contact with those on the outside and don't even know if dear Sister Mary down the street is still alive. Then one morning, you wake up elated because you catch word that a vaccine for COVID-19 is available and that you are indeed eligible. Returning to normalcy, and more important, as social life is starting to look bright for you. However, when needing to schedule your vaccine, the only feasible options seem to be complicated and buggy websites, multiple sign-up systems that act in parallel but do not link together, extensive waits to enter the scheduling portal system, and a lack of outreach, causing you exasperation and exhaustion when trying to set up a vaccine appointment. Once you are able to schedule an appointment, you must toggle getting there, where the most cost-effective options, Revel, mopeds, Lime scooters, and city bicycles don't seem to cater to people with similar needs as you. And when you do manage to get to the vaccine site, the lines look like this, with not a single place for you to sit and rest your feet after all of what you have endured. When it's all said and done, you are enraged with our healthcare system as it doesn't seem to add up. In 2018, more than 1 in every 4 Medicare beneficiaries had no internet access at home. Those without internet access were more likely to be 85 years of age or older, members of racial or ethnic minority communities, and from low-income households. For the almost 13.8 million older adults in the US who live alone, asking for help with tasks such as signing up for a vaccine or getting to the appointment may not be an option. And between 2 million and 4.4 million older adults are homebound. Most are in their 80s and have multiple medical conditions such as heart failure, cancer, and chronic lung disease, and many are cognitively impaired. And more importantly, only 14% of older adults made up all COVID-19 cases early on in the pandemic. Yet older adults comprised 80% of the nation's COVID-19 related deaths, which leads us to ask why those most vulnerable to the virus were having the hardest time getting vaccinated. What was the plan? One might say at the outfront, the plan was that there really was no plan. Because while it might seem like enough to just say older adults would be first in the vaccine line, we must consider what it actually takes to get to the line. It is much more than granting access. It's removing the structural inequities that too many of us have become victims of. Structural inequities are the systematic disadvantage of one social group compared to other groups with whom they coexist that are deeply embedded in the fabric of society, in which societal resources and opportunities are differentially allocated. In the case of older adults and access to the COVID-19 vaccine, that's internet, transportation, and digital literacy, among many other barriers. The average monthly cost of internet access is about $70, which can be out of reach for those who can barely afford groceries. Vaccine access, however, is just a microcosm of structural inequities. We see structural inequities in access to healthcare, lack of pharmacies, hospitals, and providers, inequities to access to healthy foods, where you're more likely to see a bodega in a low-income community as opposed to a Whole Foods, inequitable opportunities for socialization, being without walkable neighborhoods that are clean and safe, lack of affordable housing, and lack of access to shared quality resources such as parks and schools. The most commonly disadvantaged groups when it comes to structural inequities are older adults, racial ethnic minorities, low-income groups, those who are socially isolated, individuals who are homebound, and those who live in rural settings. This conceptual model, developed by the National Academies, helps us work towards community solutions to promote health equity. We must first understand the context in which health inequities exist, which is this outermost circle and background. Structural inequities encompass policies, law, governance, and culture, and refer to race, ethnicity, gender, or gender identity, class, sexual orientation, and other domains, which any one of these domains can be actual or assumed characteristics. These inequities produce systematic disadvantages, such as unequal access to COVID-19 vaccines, which lead to inequitable experiences of social determinants of health, such as transportation, housing, income and wealth, and physical environment, and ultimately shape health outcomes. Structural inequities are an umbrella concept that encompasses specific mechanisms that operate at the interpersonal, institutional, community, and systemic levels of a socio-ecological model. And I hope to discuss a little bit more about this. But very importantly, when we think about structural inequities, I must note that they are man-made. Therefore, they can be broken down. With that, I want to end off with the following quote. As a country, as a community, we are only healthy as the most vulnerable among us. Therefore, we must spend the time to understand what it takes to break down structural inequities and even the playing field. Thank you.
Thank you so much, Jasmine. And now we'll move on to Jennie.
Well, thank you. Thank you, Jasmine, for setting the stage of the background of giving us the framework that we're operating under and understanding, the lack of sense making of what we know and what should be done. And so I'll take a few minutes here to give more the narrative of work that's been done and work that we're currently doing to close the equity gap. And the generous introduction that Dr. Cortes made in the beginning about my spending nearly 25 years with one organization with a range of roles. But bottom line is it was started in a local community anchored in San Francisco in the northeast part of the city, which comprised a demographic of primarily Italian elders, Chinese elders, and Filipino elders. And other than the Filipino elders, the other two ethnic groups were people who were monolingual. So there was a real cultural difference in it. The disparity factor came into play when populations that lived in this area needed what would be nursing home care, which runs through some of our conversation today, there were, quotes, no beds at the inn. There just weren't available Medicaid beds in particular. So it became closing disparities before that phrase became to be, because we found that people couldn't access the kind of care that was necessary. And so we designed something that's now called, as many know, the PACE program. But it was like, what would make sense for people to receive care in a dignified way with quality of clinical care, but also high function and being able to really have a sense of your identity. And so all those things, you saw the photos that were shown by Dr. Travers of the long lines. Here, we place the care in the community in a geographic way that was accessible. Long story short, we now have passed the legislation that was noted by Dr. Cortes, and this designed program is available in 31 states. What is interesting to think about is it wasn't coming hard at it on a health equity lens. Again, a lot of the phrases that we now use about closing disparities weren't coined at that particular time, but it was really about the dignity of caring for people at a certain stage of life with clinical needs and functional needs and social needs, and design something around that. So we were lucky to do that literally 45 years ago, to do some sense making, as I call it. But the sense making was really about the dignity of the human person, being able to age in place and be able to speak with people in their respective languages, eat food, celebrate, and have socialization. And mind you, in those days, socialization was not valued in the same way as we call social determinants and the loneliness factor that we elevate now for greater discussion. But it's built into like what is living about and what is living at different stages. So fast forward, we were able to design a program to do this. And in essence, the early data that at the time we started, we found that many people, quotes, minorities, didn't go to nursing homes. The representation of the population wasn't there. And yet the reality is when you design programs and systems and payment incentives in ways that serve people well, it can be done. And so that's one of the takeaway messages, the ability to use your innovative efforts, the advocacy, the expertise clinically, structurally, design-wise to do something. And so I'd like to kind of fast forward to today. I happen to sit on a not-for-profit Medicare Advantage board. And one of the things that we were able to do was look at the data. And so we're talking about data and then program. And the data showed us that there was receiving the vaccines that Dr. Travers talked about. We could see that there was a 3% gap between the majority population and African American and Latinx populations. This is in the Southern California area. And so one of the things that we take to close health equity is that the CEO and the board recognize that this is an opportunity to figure out how do we close the gap between the access to vaccines. And what we were able to do was set a goal in a way that it was tied to their overall performance and compensation. So when you align incentives together to see that this is something the organization, not just by words, but by behavior and accountability, is accountable to, it can make a difference. It took 7 months for us to iterate this whole process. And the important thing about the fact that we had staff who are from the community, we brought in our own staff to really give us advice. We learned and listened carefully And I think there's a phrase called informed curiosity, not labeling, but just hearing what's important to people and who they listen to. Who were the levers of influence that made a difference, and using mechanisms like telenovelas, as well as materials that were done in different languages. But more importantly, the people they trusted became vehicles for us. And what we also did was engage a EMS startup company to provide vaccinations in people's homes. So instead of standing in a long line in some large central system, we actually sent the ambulance service with qualified EMS staff to actually provide the vaccinations. So we did these things that, like, what makes a difference in terms of people believing that this is necessary and important by trusted providers, and then also making it easy to take the pain point out of access. And so our ability in a matter of 7 months was to close the gap by 1/3, as was the goal. So I offer some of the concrete examples of what we can do when we set our structural design in a way to incentivize and reward, as well as call accountability, and the fact that people have developed a trusted way of getting information. And then we also know that what we learn from doing this, we can apply to other kinds of areas, whether it's a disease condition or just the whole sense of what is health preventive practice for older populations in certain communities. So I just offer you these examples of historically serving communities who have similar needs, but not necessarily only in the traditional nursing homes that Dr. Lynch will be talking to us in a few minutes, but at the same time of how do we help people live in their communities, age with the services that they will need, receive them in a way that is from people they trust, and also the ability to receive this preventive protection that we wanted, especially during this time of COVID. So I just give you 2 examples, the historical one about PACE, but then this really specific one right now, what a health plan can do to make a difference in closing the disparities that we oftentimes see. I'll pass the baton now back to Tara, and look forward to hearing Dr. Lynch.
Thank you so much, Jennie. Susan, you're on deck.
Well, thank you, Dr. Cortes, for the invitation. And what I want to do is I want to pull together many of the critical themes that Drs. Travers and Hanson raised around some of these issues. So talking about equity, the role of data, structural design, and specifically incentives and accountability in the work that I've done for my career, which is to really look at nursing homes that are, as the department says, the worst of the worst, and to try to think of ways to improve the situation. And so if you'll give me a moment, let me just share screen. Fantastic. So the topic that I'm going to focus on is long-term care quality as really a pillar of elder justice for all. And so I work as part of the department's Elder Justice Initiative, and we do a lot of work in the long-term care quality space, as well as financial fraud. But I'm going to focus today on long-term care quality, really as a pillar of justice for everyone. You are entitled at the end of your life and during those phases when you're most vulnerable to quality of care, regardless of where you live, your zip code, or your racial or ethnic origin. So what I'd like to do now is just to show you this graphic. You know, the Department of Justice is engaged in long-term care quality prosecution and work all across the components. The Elder Justice Initiative happens to be in the Civil Division of the Department of Justice, but this work is handled not only in the Civil Division, but in the Criminal Division, the Consumer Division, and Civil Rights Division, and all across the department. In March of 2020, the department launched the National Nursing Home Initiative, which really was an extension of what Dr. Cortes was speaking about in terms of the elder justice task forces around the country. And the purpose of this initiative was to really focus on grossly substandard care cases. Those are cases where whether an individual provider, a single nursing facility, or a chain, be it regional or national, is providing grossly substandard care to their residents, a term which I will define broadly in a moment. And what we basically did was have vertical and horizontal collaboration. So we're collaborating with our state partners, our local partners, and across the federal government with CMS, HHS, HUD, and the like. When there is grossly substandard care in a facility, there are a couple of options. There is a civil option, which involves oftentimes a False Claims Act, which is a case where a whistleblower identifies this type of problem, or, as was mentioned earlier, data is mined to identify poor quality as it is shown in terms of health inspections, in terms of numbers of staff, which is a huge problem, in terms of quality indicators like pressure ulcers, falls, et cetera. So there are civil remedy under the False Claims Act. There's also a related administrative remedy oftentimes, which HHS, Office of Counsel to the Inspector General, brings in as what is called a corporate integrity agreement. This is an agreement oftentimes that a provider will enter into with the government, where the government has unfettered discretion to go in and observe, take data on, and otherwise engage with the provider for a 5-year period to hopefully improve quality and embed some of those good practices where there are the appropriate incentives and the accountability. So after the government steps out of this agreement with the provider, those good quality systems are in place. Second, the department has criminal remedies, and there's criminal healthcare fraud. Obviously, there's mail-in wire fraud, as many of these requests for payment come over the wire. There's also tax fraud, which sometimes accompanies some of these cases. Obviously, grossly substandard care was exacerbated by the COVID pandemic. And the truth of the matter is, across this country, there is not necessarily equity as far as quality of care. And there are pockets of better care and less good care really across the country. COVID laid bare, as we hear, some of these systematic problems. And as I say, in some cases, there's a poor quality system that is like a dry field. And when COVID came in, it was like a match on that dry field, and it lit the field, and we had horrible problems in nursing homes. And this is, no news to anyone that initially 40% of the COVID deaths were related to nursing homes in this country. Some states had as many as 80% of COVID-related deaths in nursing homes be in nursing homes of the state-related deaths. For example, New Hampshire had a high percentage, as did some of the other northeastern states. There was obviously huge problems in quality of care, specifically as it related to infection control. And so CMS was very focused on infection control problems. Obviously, COVID is an infection, slightly different than the typical types of infection problems that you would see in nursing homes, such as, scabies or something of that nature. However, there's no question that infection control was a major problem. And why were these problems there? What were the systematic problems? What were the structural changes that needed to take place and still do today? As I say many times, there are three: staffing, staffing, and staffing. Many facilities then and now do not have adequate staff to care for their residents. They're not adequately trained, and they're not adequate in numbers in many cases. Sometimes staff were moved between facilities during the COVID timeframe early on, passing the virus from one to another. And nursing facilities made the choice to maintain full capacity, even though they knew that they were understaffed. Staff weren't trained in the use of some of the key equipment. This was true with ventilators and some of the earlier infections in the western part of the United States. And there was this problem across the healthcare system of inequity, not only in nursing facilities, that is to say, some had higher quality than others, but also across provider types, where some of the nurses were being poached from the nursing homes by hospitals who were paying more, and therefore the care was even more problematic in the nursing homes. there were a couple of studies that were done early on by the Kaiser Family Foundation, which indicated just a higher percentage of deaths in nursing homes that had a higher percentage of African American or Hispanic residents, higher percentage of infections, both of staff and of residents, basically showing gross inequities in nursing facilities and higher percentage of Medicaid nursing homes. Another area that was highlighted as well is lack of culturally competent care in some nursing homes. And a study was done around Native American residents in nursing homes, both on and off reservation, and the opportunity to really participate at the end of their life in some of their cherished ceremonies and culturally focused activities were denied them with great anguish. And so, again, inequity in terms of quality and inequity in terms of culturally competent care. So what do some of these grossly substandard care cases look like? And why is it that we have to be particularly focused? Well, we do not want our older adults or even younger members of our population to suffer in some of these facilities. And what I'm going to show you very, very briefly now are some slides from a public case, the Hauser case, which was a criminal healthcare fraud case brought about 5 or 6 years ago in Georgia, where grossly substandard care was a problem. And how do we know that there's grossly substandard care? Basically, this is a worthless services case, as it's known, in the legal terminology, where an entity or provider bills the government for care that's either non-existent. They say they're turning and repositioning residents, but they're not. It's worthless, or it's grossly substandard based on the outcome and the failure to follow appropriate protocols. And according to the federal regulations, a healthcare provider may not knowingly bill Medicare or Medicaid for this type of worthless care. What is worthless care? Especially egregious care, where there are widespread systematic problems in the organization, not following protocols, not having enough staff, not paying vendors that service these residents, evidence of harm to residents, everything from unnecessary falls, or I shouldn't say unnecessary, preventable falls, preventable pressure ulcers, amputations, disease, and death, and a pattern and practice of this activity. What are some of the things you'll see? Lack of wound care, ER visits for simple care that should be handled in the nursing facility, but there isn't really the staff or the knowledge to provide this. And this has been a problem as we see, some temporary nurses being moved into permanent positions, and some of the quality not there because maybe the training hasn't been done. And what types of models do we see to get to this idea of accountability that's been mentioned? It's a financial drive. The incentive is a financial gain as opposed to motivated by clinical decision-making, which leads to lack of staff competency, et cetera. And what types of problems do you see in these facilities that are focused on finances? You see the natural gas being turned off, the water, the telephones, the food not being delivered, pest control not being taken care of, fire alarm services not working. I mean, these are the core activities that every adult in a nursing facility across this nation is entitled to, and that CMS, quite frankly, is paying for. One particularly sad case, a part of this case was the national average that was spent on food. So, the national average is $5.60 per day at this time in the mid 2015 timeframe in the state of Georgia per resident per day. So $5.60. This particular facility was spending $1.83 per resident per day on food, which is just not something that can be maintained. There was diversion of funds. I won't go into the details of this in the interest of time. But while the owners were diverting funds, they were building this house for themselves. As George Hauser said, who later, as you will see, was indicted, he was like a kid in a candy store with the Medicare money. And what ended up happening was it was a race to the bank. It wasn't enough to pay the staff that was even there. Checks weren't honored, and employees basically weren't incentivized to work to care for the residents. As a result, as you can see here, this individual was sentenced to supervised release, $6.7 million in restitution, $872,000 to the IRS. And the district judge said this care was cruel, atrocious, barbaric, inhumane, and uncivilized. Obviously, nobody should be living under those conditions. And it's that type of work that we hope, these types of cases, that will stop this type of care in nursing homes across the nation.
Thank you very much, Dr. Lynch. Well, and thank you, all of you. Thank you, Dr. Travers, Dr. Chin Hanson, Dr. Lynch, for these wonderful, wonderful presentations. And I just sit here kind of overwhelmed because I am always struck by the tremendous complexity of our country with different value systems within and across states, constantly changing demographics by ethnicity and age, even within states, as we have evolved a long time along the time frame. And we are always looking at the disparities between particularly the white population, the whites, the blacks, the Latinx, the whites, the African American, Alaskan Native, and the Asian American, Native Hawaiian, Pacific Islanders. And when you look at that Commonwealth Fund report that was put on our in the chat box, it is rather striking to see the disparities between the states and health outcomes. So I'm just wondering, we talked about structural inequities occurring at multiple levels. And, when I look at the United States as a whole, I think of the great big macro system. And we have all of these little mesosystems called states within that. Plus, we have all the microsystems, the municipalities. And we've seen this with COVID so often, and all of the different rules and regulations that are maintained, that aren't maintained, et cetera. How does the structural inequities occurring at the multiple levels within our socio-ecological model happen, and what are some examples of it, and what can be done about it? It's a very complex question with a lot of answers, but we got 3 people that live in the space, so let's give it a try.
Well, I'll jump in first, since I gave a very pragmatic example of what we've been doing and will do. I think part of it is, I think about myself being a staff registered nurse, and then thinking about, what can we do about it? Because I think oftentimes there's a sense of moral distress that goes on, knowing what we know, but yet knowing there's a huge gap. So I think that one of the important things that both Dr. Travers and Dr. Lynch brought up is the ability to look at the information. Frankly, the data tells us a lot. That's one. One is our own experiences when we realize, gosh, you feel a little helpless sometimes of what can I do about what I'm seeing? So I probably will bring an advocacy lens to this, taking both data and narrative, putting it together and thinking through the decisional process that goes on. Like if we are working in a staff environment, if we're a manager, that gives us stresses both ways. We have to manage up and we have to manage down with this knowledge. And so the ability to start thinking about how does one not feel helpless, but begin to aggregate some other colleagues to do this. Because passing, for example, the work that we did in San Francisco would not have happened if we stayed local to one area, but we ended up working with other states, other populations. So I think we have to, the word we talk about today in the whole area of DEI is allies, making sure that we think about allies in our work environment. And then also thinking through, frankly, the executive level and thinking about who is both responsible and accountable, but also who might have an openness ear. Because if we do close these disparities, we do elevate it to a high quality implementation program, the whole system wins accordingly, whether it's fewer rehospitalizations, fewer hospital errors, fewer episodes in a nursing home facility that could be citations. I mean, if we can build that argument and think through our strategy and employ different tactics along the way. From if you happen to be on a management level, the ability to understand what's important to the owner of that nursing home. The ability to keep staff longer because, we don't have the moral distress, that they feel that what's important to them and to the care of the residents is aligned. The more we get a sense of moral consonance, as well as pragmatic policy and financial and performance accountability, the more we can put these concepts together, it will give us perhaps a roadmap or actions that we can take along the way. But to realize, we do have to spend some time, have some wins, have some losses along the way, but you don't do it by yourself.
Thank you very much. That was very helpful. Dr. Travers, do you want to take the next shot and then we'll go to Dr. Lynch?
Sure. So just kind of going right off of what was just shared, I would say that, thinking of the systemic level, it's what we value, collectively as a country. It's what motivates us when we think about the nursing homes and the deaths and understaffing. If we saw 40% of deaths occurring in schools, we would have had solutions in seconds almost, right? As opposed to nursing homes and how long that carried out. When we think about staffing and not just understaffing, but the amount that staff are being paid within nursing homes, thinking about certified nursing assistants making a median of $12 to $13 an hour. And every year we go and say, oh, they need to get paid more. They need to get paid more. And it doesn't make sense. How do we pay them more? What does that look like? But when we think about the people that take care of our kids, babysitters, anyone who ever has a babysitter out there, what is the going rate for babysitters these days? $20 you might be paying an hour for a teenage babysitter. And it makes sense for you because, the babysitter is taking care of your loved one, your loved child. But when we think about the nursing assistant who has multiple responsibilities, a home in many cases, maybe a vehicle, utilities, children, loved ones to care for, transportation, and it doesn't make sense for us to pay them a living wage. And then thinking about the complexity of the care that they're providing, that's the thing that I think that we need to start when considering about, what we value. And then we will start to see how we actually invest in the care that's provided to older adults and those in nursing home settings. And that one piece that also was shared about the accountability, how do we ensure that nursing homes are being accountable for the care that they're providing to residents? So just kind of the exploiting of staff and not providing the necessary resources to staff, paying the money that is actually going to resident care is atrocious. Why is that the case? So making sure that not only are we asking for Medicare and Medicaid to increase reimbursement to nursing homes, because what we see is that even if they increase the reimbursement, the nursing homes are going to do whatever they want with that funds because they're being allowed to do that. They're not being accountable to transparency and such. So we need to make sure that those funds are appropriated to areas that are going to actually improve resident care and that are actually going to increase staffing and improve the wages that staff are receiving. So that's just some overall thoughts that I would say at like a systemic level that we can think about these structural inequities and how to approach them.
Thank you. Dr. Lynch.
Sure. So I would say, it takes a village. So we're going to need federal, state, and local coordination, number one. And part of that is just purely jurisdictional. If we're trying to make sure that there's quality of care anywhere, that there's equal treatment in care, and that is to say, that the care is at very least adequate, then there are certain areas where the federal government has jurisdiction and where the states have jurisdiction, and working together, I think, will be tremendously helpful there. Bringing in our partners, Dr. Hanson, you talked about EMTs. So EMTs, the Medicaid fraud control units, long-term care ombudsman, everybody who is part of the circle here is part of the solution. I think taking a look at the regulations that are in place, certainly there are a lot of of good suggestions out there now in terms of potential changes that would increase wages, that would increase training, that would set certain standards that would be that are being considered. But even with what we have, making sure that we're looking at the survey system as best we can, that things are moving forward as best it can move, I think is super important. And then really mining the data. I mean, the data is going to tell us where there are currently inequities, where there are historic inequities. I mean, one thing at the department that we look at and matters is, what is the history going back several years of this provider's performance? Is it something that just happened during COVID, or is it something that had been, as I said, the dry field, right? So looking back and saying, well, what kind of problems have there been here? Why are there those problems? And how do we move forward? And I guess last to the value point, we're always faced with a bit of a challenge in limited resources and government and everywhere. Do we want to bring the top up to the most amazing model, or do we want to, put our efforts and what we do obviously at DOJ in terms of prosecution of looking at the worst of the worst and bringing them up? And I think that will also inform, sort of how we plan our resources and what we value.
Thank you very much. I'm also kind of in line with the same conversation. I also think about what the COVID-19 was kind of the tipping point. These providers didn't change in 2020. It's just that they became more visible as a result of COVID when we saw all of the deaths happening. Would you all talk a little bit about the inequities that were made so vivid through COVID? Because what I'm also thinking about is the socioeconomic factors that fed into the most vulnerable populations in nursing homes. We still know that the people who were in poorer nursing homes had higher mortality rates. We do know that ethnicity played a role in who lived and died in COVID, whether in nursing homes or whether in home and community-based services or just community people. What are these inequities? What do we know about them? What have we learned about them? And where could we start to address those as healthcare providers? Dr. Lynch, do you want to start? I'll start with you on this one.
Yeah, absolutely. Well, so if we look at I mentioned broadly the Kaiser Family Foundation study, right? It said that 63% of nursing homes with a high number of African-American residents reported one or more COVID-19 deaths, high in the percentage of 40%. So we think about, who are the population in some of the more vulnerable nursing homes. And there's been a lot of writing done on this now. And why is that? It could be that these nursing homes are under-resourced. It could be that they're a higher percentage Medicaid. It could be even a larger problem than simply the nursing homes, that the individuals in those nursing homes and the social determinants of health have higher comorbidities and higher, vulnerability to COVID because of diabetes and other diseases. In addition, another very tragic thing that happened in COVID that really was shining a light on inequity was the lack of access to technology. So where people simply didn't have the ability to share with loved ones because there wasn't broadband, because there wasn't technology access. So they became even more vulnerable. I know that in Montgomery did a study with LongTerm that talked about the devastating loneliness. That again was a lack of equity across the system. And then of course, vaccine access and all of that. So I think, if you're looking at your basic health, your basic access to services, and your basic access to communication, it was clearly a major problem, and all of those areas could be addressed to improve the situation.
Mm-hmm. Thank you. Dr. Travers.
Sure. So thinking about the nursing homes that are probably the most worst off, we see that nursing homes with higher proportions of Black residents have the poorest quality of care. And we look at the characteristics of these nursing homes, what is it about them? where we saw increased COVID infections and increased COVID deaths, for example, just during the pandemic. But before that, seeing lower vaccination rates with influenza and pneumococcal vaccinations, seeing higher pressure ulcers, seeing higher falls. So when we look at the characteristics of these nursing homes, we did a study just looking at the 2019 characteristics of these nursing homes. We see them being more for-profit ownership. So those are the nursing homes that can kind of use that money for other advantages as opposed to resident care. We see them being having more a higher proportion of Medicaid residents. So Medicaid is going to provide less reimbursement compared to residents who have Medicare or paying with Medicare or private funds. And then we also see these nursing homes being located more in the South, which we see that area having poor resources. And then another thing that's interesting that I'm finding in my research is that there's more LPN usage compared to RNs and CNAs in these nursing homes, which is very interesting. When thinking about just the complexity of care that Dr. Lynch brought up, in some regard, you can say, oh, maybe there is increased complexity of care, which we did see increased hospitalization use and ED visits among these nursing homes as well. But then in that case, then we should be seeing greater hours of nursing assistants and greater hours of registered nurses as well, who are going to be able to provide, the assessment needed, but instead we're seeing fewer hours in these nursing homes compared to nursing homes with no Black residents, and then a higher use of LPNs. So the question is, why this higher LPN use and why lower use of registered nurses and nursing assistants who provide a lot of that day-to-day work care for the residents. And it could be something that Dr. Lynch brought up earlier as well when thinking about the exploitation of a certain staff and thinking about LPNs and how they're not being used in hospitals as they used to be used. So where are they actually being able to find work? And that could be another thing where LPNs just had no other places to go when it comes to nursing homes and that increased use of LPNs. But that's some of the characteristics that we're seeing with regard to nursing homes. And then just kind of going back to the lack of access and just thinking about in the community setting, what I shared with my presentation and, thinking about internet use and getting to appointments, transportation, mobility, that's nothing new. It's not new to the pandemic. And of course, the pandemic just shone a light on those issues, but that's been a problem when thinking about access and how do we ensure that older adults in the community setting or in the nursing homes kind of get that access and the services and resources and supports that they need, that they're able to know and be knowledgeable of these services and supports, and they're able to actually access them.
Thank you. Dr. Hanson.
Well, it's a complex set of issues that have been arrayed here. And I know that our focus of conversation has been on the nursing homes. And the nursing homes are an entity that structurally has evolved. And so that many people realize that the Medicaid payments that go to nursing homes, by and large, are not sufficient. But the way the nursing home industry has evolved, even though there are publicly run nursing homes, not-for-profit run nursing homes, and for-profit nursing homes, there is a structural design that has created some of the financial inequities that you're talking about right now. Here in San Francisco, we have a 500-bed public nursing home, and their infection rate and PPE use, the infection rate was extremely low, and there was adequate PPE that was used. And so it's possible to have nursing homes run and operate in a way that does care for its residents with higher quality. The tough part is structurally that we in nursing don't have a direct impact on is the way nursing homes are financed from real estate perspectives and from payment of care perspectives. So that's a tough one to battle. And I know that the John A. Hartford Foundation right now has an initiative to really take a look at, what is the redesign of nursing homes that will make it possible to hopefully both be more appealing to older adults? Because I think some studies have come up in the past week that a lot of older adults would really not want to go into facilities now. But how do we redesign it? And so I think that's a body of work that's happening, because not all nursing homes, as Dr. Lynch knows, are necessarily quality. But what she has to focus on in elder justice are those particular ones. But there are good examples of continuity of care, best use of staff, and the ability to have a safe operating facility. I want to, though, offer that in the Build Back Better Care, I forget what the exact initiative is on the federal level, there's $150 billion set aside for the development of home and community-based services. And our ability to start building the community infrastructure so that it's not focused on a physical institution, but having people receive care in their home environments and their local communities in ways that would support their well-being, their safety, and their highest function that goes on. So I think we both manage the high-risk environments that certainly is represented by the work of Dr. Lynch and her team. But then we also start building bridges to where will all of us who are older hopefully get better care options in the future. And so building on that infrastructure network will be important, because frankly, right now, it's not sufficient. We have in-home supportive services, oftentimes funded by states to help have home care, but it's still not a well-developed, universally strong program. But let's start building a long-range effort of where home and community-based programs can thrive, and then go further upstream. Can we help people manage their health conditions like diabetes, like congestive heart failure, like pulmonary breathing problems better in the community, so that people may not fall into that cliff of needing all these intense services. So I think this is a multifaceted kind of ecosystem approach to thinking about where does chronic care happen today? In what way? Are there bridges to kind of next gen possibilities as more people age and live longer? So I just offer a very different spectrum from what I've been talking about very clinically about getting vaccinations in the homes. But we need to step back and really think about the design for the future. And, there's a little hope on the way that community-based funding will help in our developing an infrastructure to care for chronically fragile people in the community.
And I'm going to try to tie up some of the questions that were in, because there's a lot of overlapping in the questions that are both in the chat box and the Q&A. And I want to point out that we were looking in this webinar on disparities, and some of the disparities that exist within long-term care when we look at older people are also a result of life experiences. And the people coming into those nursing homes many times are already vulnerable because of the life experiences, socioeconomic environments under which they have grown and developed and gone through their life's journey, which puts them at greater risk in the nursing homes. I don't think the intent at all was to pan nursing homes. Certainly what we need in nursing homes is financial restructuring, because it is impossible for them to recruit RNs when RNs can make $20 an hour more across the street in the hospital. They don't go into long-term care. Recruitment and retention in nursing and long-term care, especially now after COVID, is a huge issue for long-term care. We also don't prepare our nurses for long-term care. We prepare them for hospitals. We give them acute care backgrounds with very little experience in long-term care. And when we do put them in long-term care, we put them in when they're in their first year, and they are so petrified of people with dementia that they never want to set foot in there again. But the financial structure, and one of the questions was, how would people feel if we moved some of the money that goes to hospitals into nursing homes? Would the public stand for that? I don't know. And I think we have to think of it differently than moving money from one to another. But to Dr. Chen Hanson's point, how do we restructure our nursing homes, including appropriate financing, so that they can give quality care and have the appropriate income? I think we need to say, what is the appropriate way to finance them so that they can meet the needs of what is the most vulnerable population of our aging people. It is the people who have the most complex needs, and many of them have come from those backgrounds. Those inequities had been exposed to inequities in their lifetime that have made them into this vulnerable population. So is there a closing thought, a 30-second closure from any of the panelists? Susan, you're on.
Yes, I will jump in with a 30-second closure. I think that it is absolutely critical, even as, we fortunately are going to have money moving into home and community-based services, that we stay focused on nursing homes, because there will always be a need and a role for those. I certainly agree that there are good nursing homes and nursing homes that end up across the table from the Department of Justice. And so we, obviously want to be very careful in saying that it's the grossly substandard care cases that the department looks at. On the issue of payment, just to be clear, I think that, we have to be robust on our oversight and accountability, no matter what amount of money is ultimately decided on in terms of payment streams, because I think there'll always be those, like as we showed in the How to Serve case, where no matter the reimbursement, there will be fraud. So I think we just have to be, on our game in that regard to protect the most vulnerable among us.
Dr. Chen Hanson? Oh, you're on mute.
Just realized that. Apologies. I'd say that let's still hold this in our hands in a way that's precious. There's so many ways to look at this, both kind of the negative consequences, but also the fact that there are ways to care for people that frankly will help people age well. And even as they are frail, there are increasing ways to do this. I certainly agree with Dr. Lynch. We cannot take our eye off the ball for the areas of egregious poor performance, but let us continue to build the path and the homes for ways that we can care for people as they age, and can they age with frailty at home? And I think that is possible, and it takes all of us around the table to focus on our part of the segment that we can do something about. So let's lean in.
Thank you. Dr. Travers.
Yes, thank you. I would just leave off with saying, of course, nursing homes in general are not going anywhere. We're going to have a need for nursing homes. And I agree that there's been monies invested in home and community-based services as if there's not a need to invest in nursing homes. I would say that there's just multiple layers within each setting that need to be addressed and need to be thoughtfully considered when thinking about the care that's being provided to each individual in each setting, and understanding what the needs are and taking this holistic approach and individualized approach as well. And I'm excited for what's to come, what was shared before about the match within nursing homes. Definitely COVID has been a 911 or a 9/11 moment for nursing homes. So I think change is coming.
Thank you. Thank you so much to our panelists. This was all the comments I'm seeing in the chat box were so much. Thank you so much for the very thoughtful, provocative discussion. It was provocative. I appreciate your thoughtfulness and your input, and I thank the audience for being great participants. And I wish everybody a very happy holiday season, and may our new year be everything we all hope for. Thank you so much. Bye.